Lisa, and thanks everybody for a great conversation so far. This part of the discussion is to really just stimulate some perspective in terms of looking at pharmacy in a broad sense of where we could potentially go in this area. There's three parts to this discussion. I'll cover just setting the stage and giving an overview. Becky Sneed from the National Alliance of State Pharmacy Associations, National Becky, will give perspective from the state, and then Erin Mullen will give perspective from a declared emergency and how things kick in. And all three of us will then be able to facilitate the discussion, as well as our other pharmacy colleagues around the table can chime in here as well. But really we want to set the stage for the discussion. So I'm going to start from the perspective of what we're doing here is part of what we in pharmacy and other stakeholders in the public health community are striving for. In the immunization area, we have something called the immunization neighborhood. I call it the 3 C's. It's collaboration, it's coordination, and communication among providers to provide a service, provide immunizations to patients in need, and to improve the public health of our communities and prevent vaccine-preventable diseases. That same description can apply here as well. We've been spending a lot of time over the last several years talking about opportunities of collaboration between public health and pharmacy. And these are just 2 documents that have come out of that collaboration between pharmacy, NACCHO, ASCO, CDC, and other HHS entities, trying again to develop frameworks that public health departments can use to move this agenda forward. I put this together just to kind of give us a focus for our discussion, because we could talk about for days the non-emergency patient care services that pharmacists can do in their communities today, the non-emergency immunization services, when there's a declared emergency involving immunizations. But today's discussion is really focused on the bottom left box, which is a declared emergency for patient care services. Prescribing of antivirals is what we're talking about here. So as we're looking at this model for today's discussion, we're really talking about when a declared emergency is done or is a need in a community, and we need to get antivirals to patients who need it. What can we do? What are the barriers, and how do we overcome them? So, as a lot of you in the room are aware, when an emergency is declared, the governor has the authority to declare it. In some states, there's actually state law that puts in place procedures, and Erin and others will spend time going through that again and some of the challenges of that. But we want to set the stage. This is what we're talking about: public health emergency, public health need. From the pharmacist's perspective, there's a broad array of services that pharmacists can provide today just based on our scope of practice, as well as local privileging. So health systems or relationships with medical clinics, those establish what pharmacists can do, or are an opportunity to establish what pharmacists can do. And these can include medication review, lab interpretation, lab ordering, screening for influenza is one example, medication reconciliation. But the one thing I want to make sure that everyone understands is some of these things you do not need a collaborative practice agreement for the pharmacist to do. It's part of their scope of practice. So I don't want us to get too focused on everything that a pharmacist is going to do has to be under a collaborative practice agreement. No, there's some things that pharmacists can do without that, but where we can't, collaborative practice agreements provide us the opportunity to be able to do that. Again, this is a formal relationship between a pharmacist, physician, and in some states it's allowed to be done with other prescribers. So depending upon that state nuance, we'll determine who can enter into one of these agreements. It describes the functions that the pharmacist can do, and as I talked about again, just reiterating the point, it expands the depth and breadth of what a pharmacist can do in working as part of that healthcare team. Back in early 2000, actually late 2013, there was a paper that was published in the Journal of the American Pharmacists Association, a project that was done between CDC and the American Pharmacists Association Foundation that brought together stakeholders, and some in this room were participants in this process, of looking at what were the key elements involved with the pharmacist collaborative practice agreement. What were some of the nuances that would make this type of opportunity work? And so this stakeholder consortium came up with some guidances, 7 key things that were identified for what would make these type of relationships successful. And while not all these apply to the situation that we're talking about today, it does give you some perspective as you're looking at in your local health department or your local communities entering into these relationships. What are some elements you need to think about as you do this? One is consistency of terminology, and I think Andrew hit it up, right up front. The different terminologies that are used in different state practice acts sometimes are confusing when people are talking about that. So get some commonality, get some agreement up front of what are we talking about. Allow healthcare providers to enter into these arrangements that meet their needs. So while we want to have models, we also have to allow for some customization for the particular local needs between that physician, that pharmacist, that patient need. Third is, we want these to be able to create and expand an infrastructure that allows these CPAs to expand and care. That's the whole purpose of what we're trying to do, is to expand access to important services for patients. Keeping the patient central of what we're doing is what's going to drive us to success. We also want to make sure, as somebody mentioned earlier, that we do embed electronic health records and the electronic communication. Again, as I talked about, the success of that immunization community or that public health neighborhood that we're trying to develop is the communication among providers. So having that connection electronically so that providers can communicate and document what they're doing is important. We also want to have that trusting relationship between the patient, the physician, other providers. Again, we're promoting increased access for patients to these services. Aligning incentives for everybody involved in this and looking at the process that's meaningful and it produces the outcomes that we want to produce. And then, of course, there's always going to be a component whenever you're putting in one of these arrangements, making sure that people are educated, people have the same consistent messages that they're delivering. So in a viral area, we want to make sure providers, not just pharmacists, but physicians, nurses, and public health are all delivering the same consistent message, that we don't have one provider group delivering a different message from what the other providers are doing. So our goal in this discussion is that for pharmacists to fully engage in the dispensing and evaluation process for patients, what do we need to have put in place? What are the barriers? And as Lisa talked about earlier, the timing for patient access to these medications is crucial. It's a little different than some other medications that we're talking about. For these to be successful, it has to be done in a timely manner. So as I now get ready to transition it over to Becky to give further insight, we know through experience, based upon what we've already done in the antiviral pilots and things that have happened on the state level, state ability, state authority varies. We've got some states that require prescribers to initiate the diagnosis. We have some that they need to order for a specific patient. Some require it to happen in certain locations, and some say that pharmacy, when they're doing that, have to have a certain setup within their practice. So now I will turn it over to Becky to delve into those a little further. And you want to do it from there, or you want to go ding next slide?
I'll go ding next slide. How's that? Ding. So I think that it's incredibly important, a couple of the key messages that I've heard Mitch and others say. Understanding what the current environment is for pharmacy to practice under collaborative practice agreements is important in building the sense of trust as a pharmacist as part of that healthcare team. But I really hope that we don't get ourselves thinking that this is the venue that we will need to utilize in an emergency, because depending upon the state, what we really need to do is do an analysis of their emergency provisions and what can be waived and can't be waived under an emergency, and how the practice team will operate to meet a public health need. Because I would assert that a lot of the provisions that I'm going to highlight now, as far as the differences of collaborative practice agreements, wouldn't be applicable. But what it does is it allows us to, in a state where we don't have an emergency, to have that comfort level of working as part of that team. So it's important to know that there's a patchwork of state laws as it relates to collaborative practice agreement, but I would really urge us not to bind ourselves to have to make that infrastructure be the one that works during an emergency. So there are 45 states in the District of Columbia where pharmacists, yes.
I'm sorry, this could either be before or after your presentation, I could ask this question, but when a pharmacist finishes school and goes into practice, is it a standard thing that they go and get a CPA, or is it sort of an ad hoc thing based on certain conditions?
It's based upon their practice environment and what type of patient care services they are going to be providing in that patient care service, the practice environment. So yes, a pharmacist can graduate and is absolutely trained and prepared to be able to enter into a collaborative practice agreement if they have a patient population that needs that management. And typically most collaborative practice agreements that prescribers enter into are for the management of chronic disease.
So like a pharmacist in Walgreens, for example, would they automatically get a CPA in place? Or is there, what I'm looking for is an answer to the question is there a standard place where this occurs?
It's again, as Becky said, it will depend upon the patient care activities that they're wanting to do. Again, their scope of practice covers a lot of what a pharmacist does in managing a patient's medication and their therapy needs. Where the CPA comes into play, for example, would be for if they're going to do immunizations, then a lot of the states require them to have a protocol with a prescriber or the public health department, or under the state law, it allows them to do it. If they're going to do anticoagulation therapy management, then they're going to enter into probably a collaborative practice agreement or a collaborative drug therapy management agreement, whatever state you're in and what you need. So it's going to depend upon the patient needs, but it's not automatic that every pharmacist has to have a CPA.
Okay.
Yeah, and it very much varies state to state, practice by practice, and so
So you couldn't say more often in hospitals than community settings, for example. There's no.
And in a lot of our health systems, and absolutely for Doug, you don't even need the structure of a collaborative practice agreement to be able to do a lot of the clinical services that pharmacists do, because they're part of that system and they're under that infrastructure. I think that in this view of a collaborative practice agreement would be where you have a pharmacist that may be practicing at Walgreens that's partnering with the physician's office practice that's independent, or with a hospital, to be able to bring all the partners together under a patient care system, but not under a health system that's contained where everybody has access to the medical record and whatnot.
Jim, I just wanted to point out that there was the way you worded your question, the pharmacists don't automatically have a collaborative practice agreement that just lets them prescribe. They're structured for what patient population, what disease states, and what medications.
You want to give the hospital?
Yeah, well, as Becky mentioned, really within the health system, typically there's a privileging and credentialing process, and they operate within the construct of that system.
The word calls them for privileging. But if you and I can tell you that if you look at the analysis, I worked very closely with CDC when they did their analysis, and even by the time they got it through the approval process, it was already outdated and inaccurate, because the state laws changed that frequently, and there are some things that are done. Michigan's a great example that there's not words on paper in a statute, but rather it's an interpretation that has been given to the health professions as to what pharmacists can and can't do. So you're not going to find a code section for it, and so you have to put a patchwork of what you're able to find in your analysis versus what the practice actually is in that given state. So But of that analysis, just to give you some idea of where the similarity and where there's differences, 45 states and the District of Columbia, pharmacists are able to enter into a collaborative practice agreement. Some, as we noted earlier, use terms other than CPA, but I'm just using CPA for to add some level of consistency here. 5 states, pharmacists are not able to enter into a CPA, but of those 5, 2 actually have enabling legislation. The regulations just haven't been promulgated, and in one case, it's been over 6 years that we haven't gotten the regulations promulgated because the regulations were deferred to a joint activity between the Board of Medicine and the Board of Pharmacy, and the Board of Medicine has decided that they don't want to convene that joint activity. So even when you pass it in law, some people would do the analysis as, well, it says right here they can do it, but they actually haven't been able to do the companion regulations that are necessary to implement the provisions there. And so what those 2 states will have to do is actually go back to the legislature and then get the legislature to mandate a time frame in which the regulations are promulgated, or a different process for those regulations to be promulgated. Next slide. In 38 states plus DC, pharmacists can initiate and modify drug therapy within their practice agreement. That means, of course, that there are a few states where I could only modify, so a person would have to already been diagnosed, implemented on a particular regimen, and I can adjust it if they're not getting to goal, but I can't start them on a different therapy. However, the majority of them do allow pharmacists to initiate. There are some limitations within those 38 in regards to what medications and practice settings in some of those states. And I'll talk about that again in just a minute. In 2 states, they are where I think the CDC and the APHA Foundation were going, where it is very, very broad, saying that it's really the determination between that prescriber and that pharmacist to determine the components of that protocol. So there aren't very rigid things that says, yes, you can initiate drug therapy, because one prescriber may want, for patients that are on blood thinners, the anticoag therapy, they may absolutely want the pharmacist to initiate therapy because they're going to want them to change doses or change products if one product the patient's not responding to. But that same prescriber may decide, when you're managing my patients with diabetes, I only want you to adjust therapy, I don't want you to initiate. So it's the law is very enabling to the practitioners to determine what it is that the pharmacist would do within that CPA. Next slide. Site limitations. We talked about, could a Walgreens do this? Is it limited to a health system or a clinic? In 39 states plus DC, there are no restrictions on practice settings. 5 states explicitly exclude pharmacists practicing in community pharmacies for participating in collaborative agreements. And 1 state is extraordinarily rigid, and if anybody can guess the state, then I'll give them a prize, not the pharmacy folks. But that only allow CPAs within a teaching hospital. So even hospitals that aren't teaching hospitals, you can't have a collaborative practice agreement.
Come on, tell us.
Yeah, I say Texas.
New York.
Oh.
New York.
Yeah.
But I would say New York has one of the most liberal emergency provisions. So I think pharmacists could absolutely initiate antiviral medications if there was say, an emergency under protocol in New York. But under normal general practice, we would be very limited in what we could do in the hearing for patients.
Can I just,
Yeah.
Michael and your folks, are you guys with the medical center? I know most of the poison centers we visited have been in the basement of one or somewhere like that.
No, we're out of the airport, actually. They moved us completely out of the basement. It's far away from us. We're part of Caroline's healthcare system.
Okay.
So-
I'm just wondering if there's some leverage if you're actually a hospital employee,
Yeah.
for that open
Yeah,
up
it's
some
part of the
doors here.
integrated medical system.
So maybe Doug, we can kick around some ideas about that later.
I would say generally there is a lot more latitude within health systems for authority because often it is left to the institution to grant that privilege and credential. Next. Health conditions. Believe it or not, there are some collaborative practice agreements that says you can only enter into collaborative practice if you're going to be managing these 5 chronic diseases. So they limit you to in a specific set of diseases that could be managed under a collaborative agreement. 18 states do not specify what conditions could be included, but 22 define that the specific conditions must be identified in the CPA or in written protocol, which is okay, because this could be written into it. And 6 states have statutory restrictions with basically, this is the list of chronic diseases that you can manage under a collaborative agreement.
Do they have acute illnesses as well as chronic?
Not in those 6 restrictions. They're all around chronic disease, because I think that most people envision, when they think about pharmacists as being healthcare extenders, have viewed us as that, being able to monitor and manage chronic disease in between visits with other healthcare providers.
One thing to add to that, in acute situations in hospitals, again, through that privileging process, pharmacists aren't being given the authority to do acute type, so, in codes, for example, they're given the authority to do certain things, or other types of conditions.
Yeah, they typically refer, and it's not, we all know it's not true, but I think that the assumption has been you manage chronic disease on an outpatient basis and you deal with acute care in an inpatient setting. But there's a lot of acute care that occurs in the outpatient environment, we all know. Next slide.
And just one thing to add, pharmacists do handle acute care situations.
Sure.
They'll get on the phone and call the physician, the patient has one, or send the patient to an emergency room. So they are handling acute conditions. What they do with it, is up to what the situation requires.
This is a rather interesting analysis. I put it in there just for perspective, because it's one of the ways we have sliced and diced it, and that's in ordering of labs. In 30 states, pharmacists are able to order and interpret lab states under their collaborative practice agreements. 3 states plus DC allow pharmacists to order labs, but there are some limitations. And 17 states are sort of silent on this, of whether we can order and interpret lab values. This is slightly different than the pharmacist actually doing a CLIA-wave test to test your blood sugar or your cholesterol. This is, you are on a particular medication and I want to, let's say you are on a statin for your cholesterol and I want to order a lab to tell me what your cholesterol is, and then I want to interpret those results and decide whether we need to adjust your statin medication. So that's the reason why this language is often linked into collaborative agreements. But it doesn't mean outside of a collaborative agreement that a pharmacist also couldn't order or initiate a lab test. It depends upon what other authority exists, and so it's one of those areas that is sort of gray. I don't want to give the impression that in the remaining states the pharmacist couldn't actually conduct a lab test, because they absolutely could do a point of care test or a CLIA-wave test. And that's the way that I had sliced it, diced it, to be able to sort of give you a current state of the environment, because these are the ways they're currently defined. I think Erin is going to provide a different lens of collaborative practice as well as emergency authority, but I just want to absolutely echo that this is really good foundation for us to understand the current practice environment of pharmacists. But I don't think this is the lens that we need to be looking at when we think about what a pharmacist authority would be in an emergency, because it would defer to the language. Minnesota was a great example. The language that says that, and that wasn't even tied to emergency, they're under a physician's practice, they may be able to delegate, and they may already be able to delegate the initiation of therapy to a pharmacist. That's not going to be captured when you do an analysis in their collaborative practice agreement. So I think that we have to be thinking and having these discussions now when we're not in an emergency, and start identifying the things that we do need to evaluate to be able to find that environment that's going to best meet that local need, as well as that state authority.